I want to thank the organizers for letting me present my case. In the interest of disclosure, this case I presented a couple weeks ago in the Pisces breakout session at Sky, but I submitted a few cases and you guys chose this one, so I'll present it again. I did not come up with the title. I'll give credit where credit is due, and that's the Pisces Committee, so thank you for this. So my case is, I have no disclosures, is a 44-year-old female with tricuspid atresia with BSD and normally related great arteries. She was my first interaction with this type of anatomy, but she had her initial palliation was a patch VSD closure with a Bjork modification Fontan with a 25 millimeter RA to RV conduit at 6 years of age. And then she developed progressive conduit dysfunction and underwent a second conduit intervention with a 30 millimeter porcine valve conduit, which contains a 31 millimeter CE valve in 1985. She was asymptomatic for about 33 years until this past summer. She developed palpitations and exertional fatigue. Holter demonstrated intermittent atrial flutter. She was initiated on Sotalol. Her exercise stress test showed a blunted heart rate response, and on echo there was a very dilated RA with a mean gradient across the RA to RV conduit of about 8 millimeters of mercury. My colleagues in the ACHD division referred her for transcatheter valve replacement in the RA to RV conduit. Having not interacted with his anatomy before, I got a chest x-ray to understand how the conduit orientation was in the chest and elected to come from below. After gaining access with a 16 French Gore dry seal sheath that I pre-closed with 2 other sheaths in the left femoral vein and artery, got initial hemodynamics. There was a 45 millimeter of mercury gradient across the RA to RV conduit under anesthesia. Started with a rotational angiogram to understand the position of everything in the chest. And then did a traditional angiogram, which demonstrates at least moderate calcification of the conduit that's fairly immobile. We then performed coronary angiography, not knowing where the right coronary artery kind of sits in relation to that conduit, and it was felt to be remote. But again, you can see flattening of the conduit on the lateral projection with a lot of calcium built up there. So, performed some measurements on the device. It was consistent with what we thought it was. Used the valve and valve app to understand what the true ID of the device was, which was 27 millimeters. And then decided to take a 26 millimeter Atlas balloon just to see how it would react as we distended it with the intent to place a sapien valve in, 29 millimeter sapien, and then post-dilate it. There was not a lot of movement with blowing up the Atlas balloon. It's a 26 Atlas. Yeah. I think they make a, yeah. Yeah. So, one of the nice things about the Edwards Sapien S3 is the Edwards folks have their own sheath that's 16 French, and so we decided to change out the 16 French Gore dry seal sheath with the 16 French Edwards E sheath, which is an expandable sheath, so in the body expands as you advance the valve through it. We chose a 29 millimeter Sapien S3, loaded it onto the delivery system, asked the rep to put some extra volume in the indeflator, and then we went up with the valve. Got it in good position with our Lunderquist wire, and then at 26 milliliters, which is not the full volume that's required to deploy the valve, we had balloon rupture. So that's my oh crap moment. My sapien experience is relatively limited at this point. So my question is, is the valve stable since we didn't receive or didn't get up to our full volume? What type of a balloon rupture is it, circumferential or longitudinal? And how do we get it out of the body? The Edwards E-sheath, while preserves some of the French size going into the vein, is not rigid distally, and so just pulling it out of the sheath is not a typical option. So the question, do we need new access?
So yeah. 29 valve.
Yeah.
And it ruptured, how do you know it ruptured at 26?
Because that's when we were watching. Yep.
But you had how much 33 ml?
We had 34 mLs in it. We had 34 millimeters in the indeflator, but it ruptured at 26 mLs. So we had not fully deployed the valve when the balloon ruptured.
You had a
It looks like a
31
waste.
cv stenosis that didn't size much bigger than 27 IV.
Yeah.
The valve should be deployed. You probably
True.
could have sized you saved it, you could have gone 26 but it should be deployed. It's done.
Well, it did look stable, so that was the good thing. So then we had to focus on how to get the balloon out. Even though we knew that the Edwards E-sheath was not very rigid, we tried to pull it out. That didn't work. We pulled everything down to the leg, and we suspected with all the resistance that we were hitting, we had had a circumferential balloon rupture, and we were actually getting E version of the balloon where it had ruptured. Because of that, we didn't want to actually just pull everything out of the femoral vein because we thought we would create more damage. And so the question is then, how do we get it out? And so do we come from above, do we create a rail, or do we try and get a bigger sheath in there? The problem, of course, is the delivery handle of the commander system, and so you can't just perform a sheath exchange. So the question is, how do we get access to the wire without losing control of the balloon where it had burst? So we started cutting down on the commander delivery system and found the 3 layers. So there is the pusher layer, the balloon layer, and then the wire lumen that's attached to the carrot, and then the wire. So we did this all very carefully, making sure that we didn't cut the wire because that would obviously not be good. And so we were able to remove the handle of the delivery system. We were able to pull out the pusher and the balloon catheter portion of everything, leaving just the body of the wire lumen with the distal balloon carrot and the Lunderquist wire, which was still in the right ventricle. And so then we just figured we'd put another dilator and sheath over the wire and the wire lumen. Of course, every dilator that's attached to our larger sheaths is designed for an 035 wire and couldn't accommodate the larger diameter of the wire lumen that's part of the commander system. We luckily had access to the Amplatzer Torpy exchange sheath, which is designed to accommodate the delivery cable of the Amplatzer ASD devices. So it actually has a wider diameter of the dilator lumen. And that was successfully able to go over both the wire itself and the wire lumen of the commander system. So we were able to reestablish venous sheath, but this was a smaller sheath than even the 16 French that we started with, albeit stiffer, and we were still unable to pull the balloon through it. So then the question is, what do we do next? We attempted to thread a snare up through the sheath from below and try and crimp down the balloon to get it through. That was not successful. And then decided to go from the neck and try and snare it from above, starting with an 18 French gore dry seal. We were able to successfully snare the wire and create a right IJ to our right femoral vein veno-venous loop. But even as we snared the balloon, there was just the balloon itself had occupied too much space. It was even bigger than the IJ itself in its current state. So eventually decided to upsize the 18 French gore dry seal to a 26 French gore dry seal, and were able to snare the balloon and actually pull it out through the veno-venous loop in the neck. So then the question is, are we done? Despite the feeling that it had probably been deployed, we elected to go back and post-dilate it to make sure that we had fully deployed the valve and that it was stable. We went up with our 26 millimeter Atlas balloon, and then we were left with a 2 to 3 millimeter mercury gradient across the RA to RV conduit. We felt that we had successfully gotten out of Dodge and called it a day. We did ice, as we do with all of our valve cases. There was no significant paravalvular leak. The valve looked like it was in good position, and our Doppler gradients were good. We were able to extubate the patient in the cath lab. We admitted her for observation. We had not pre-closed the neck, so she developed a big right neck hematoma despite a figure of 8 stitch. post-procedure day. One had a 3 millimeter mercury gradient across the valve. She was discharged a day later, and then 1 month later had no significant symptoms. She had improved, and then her Holter demonstrated decreased atrial ectopy. So I think in conclusion, I think the big learning points for me was understanding how all the systems that we use are actually constructed. I had never taken apart a Commander delivery system before, but it's, I think, very helpful to know what components are there. So the inner layers of the Commander system, there's the pusher, the balloon, and then the wire lumen, which is metal reinforced. And then knowing that most people probably have access to the exchange sheath, which has a wider diameter lumen, I think can be helpful if you get into trouble. And then I think big sheaths, multiple access point, and snares are obviously your friends, and everybody needs all the tools to get yourself out of Dodge going forward. So that's my case.